It takes 1 minute to warm up.
We're good with the clicker.
Good morning, ladies and gentlemen. My pleasure to introduce Dr. William Arnold from Rothman Institute.
Good morning, everybody. You can hear me okay?
Good morning.
So thank you for giving your time for this, everybody at the Mayfair Community Center and people that we have online, I think, doing this. I'm not that electronically sophisticated, so I'll take over. Can you hear okay? All right, that's better? All right, very good. So my name is Bill Arnold. I am a joint reconstruction surgeon with the Rothman Institute. With Rothman for about 10 years now. For joint reconstruction, the joints that I work on are hip and knee. So hip and knee replacement. So when I look at people, I only see their waist down. I don't even recognize their face. So hip and knee replacement. So if you came here expecting to hear about your shoulder or your back, you'll be a little disappointed, but I'll try to inform you about hip and knee. So we'll go ahead. Diagnosis. I'm trying to sort of condense about an hour talking to 30 minutes, so I'll rush through some of this a little bit. But diagnosis for this isn't very complicated. It's usually just the story from the patient, and then, of course, the physical exam. And then their x-rays will pretty much tell a lot of the story. We have patients come in for the first time to the Rothman Institute. We always tell them to bring their studies and so forth and so on that they've had. And they usually come with their wheelbarrow filled with everything. But at the end of the day, for the things that I do, I really just kind of need this x-ray. And if everybody can see, I hope people can see okay. It shows you an x-ray of two knees. So one knee here, this would be the person's right knee, and then one knee over here would be their left knee. And to see the difference, I don't think you really have to go to medical school for this. I think you can see that there's good space in the joint of that knee, but if you go over to that knee, the two bones are actually touching. So this is a knee that shows a lot of arthritis. The two bones are actually touching. Without getting too complicated, to us, that means that this patient at this knee has worn away all the cartilage between the bones such that the bones are now actually touching. What we would call bone-on-bone arthritis, severe arthritis. So the diagnosis in terms of all the films and everything, I don't need an MRI, I don't need a CAT scan, it's really just a simple x-ray that we usually do in the office. Same with the hip. Again, this would be a nice hip, a hip with a good joint space, whereas the hip over here, the two bones are actually touching. Same sort of thing. For the hip, it's a pretty easy diagnosis that we would just get an x-ray in the office and we can make that diagnosis. So it's pretty straightforward. So you really don't need a lot of extra studies for this. That's why I like doing it. It's not very difficult. So, once you've made the diagnosis, what do you do about it? What are patients' options? So you come in and Mrs. Jones comes in and she gets the diagnosis that she has a lot of arthritis in her hip. And so, what's the next step? So, the Rothman Institute is kind of famous and made its reputation on surgery and things like that. But, we see thousands upon thousands of patients every year. And believe it or not all of them get operations. In fact, probably most of them don't, because you can treat a lot of arthritis without surgery. So here are what would be the non-surgery type of treatments for this. The first one that patients aren't always anxious to hear is weight loss, because nobody wants to hear about that. But, I think people appreciate, it's been in the news for years about the problem of obesity in this country. And unfortunately, your hip and your knee bear a lot of that weight. So, they've done, people smarter than I have done studies where they show that the force that goes across your knee joint is about 4 to 5 times your body weight. And the force that goes across your hip joint is a little less. It's about 3 to 4 times your body weight. But I think you get the idea. So, if you are 50 pounds overweight, well, to your knee, you're about 200 to 250 pounds overweight, and to your hip, you're about 200 pounds overweight. And it also works the same way. I'll have patients who are heavy. They'll come into the office and we'll talk about weight loss, and weight loss is hard to do. I mean, we all know that. We know that dieting is difficult, but I try to encourage them because they'll say, if I only lose 10 pounds, what's that going to be? But again, it works the other way. So losing 10 pounds means that you lose about 50 pounds of force across your knee and about 40 pounds of force across your hip. So it's multiplied. So weight loss is always kind of a simple one. Physical therapy. So exercise. Every once in a while, we'll actually send people to therapy. And sometimes this confuses patients a little bit because they'll tell you that the things that bother their hip or knee are activities. So why are you sending me for exercises? You know what I mean? And it's because by the time people get to having noticeable arthritis at their hip or knee, because they don't use that joint as much, they become weak. So the muscles around the joint weaken. And the problem is that the muscles don't take the load, your joint has to take more of the load. So you're asking a joint that already is arthritic to take more of the load because the muscle is weak. So this is to try to sort of reverse that process, try to strengthen the muscle so that they can bear some of the load across the joint and maybe offload the joint a little bit. So there is really something to this. Not only that, but also this works well for people who get a lot of stiffness, who are really stiff. The stiffness is a symptom of arthritis. So probably the simplest way to describe stiffness is patients will say, when I first get up in the morning, or if I've been sitting for an hour or so, when I first get up, I can't move. You know what I mean? Or you can almost hear the creaking. And they'll say, but once I sort of get moving, then I'm better, then I'm okay. We call that stiffness. That's what we describe as stiffness. And it's one of the main symptoms, so it's not unusual. And sometimes therapy can also help with that. Medications. So patients will ask, what medicines can I take for arthritis? Along the lines of all these treatments, one thing I do have to make clear is we don't have a simple cure for arthritis. So in 2015, we can put people on the moon and so forth, and we can do all this computer stuff, but we still really don't know the causes of arthritis, of simple arthritis, wear and tear arthritis that most people have. And so when I tell you about these treatments, they are just that. They're treatments, they're not cures. They won't cure your arthritis. We don't have a way to put cartilage back into your knee joint or your hip joint where there's bone on bone. These, again, are just treatments. The way I describe it to patients is it's sort of like taking chicken soup for a cold. You feel a little better, but it doesn't actually cure your cold. The same with the treatments for arthritis. They can give you some relief, but once those treatments wear off, the pain will come back. And the natural history of arthritis is to get worse as time goes by. which anybody with arthritis here, I'm sure, can attest to. You know, the pain that you get from arthritis today probably is the worst than the pain you got from it 2-3 years ago. And that's because it gets worse as time goes by. But anyway, going back to, you know, what medicines can you take? The usual main medications for arthritis are not pain medicines like we think of. In other words, you know, somebody has a procedure or something, or they operation, and they get pain medicine, you know, that they take when they go home. That's usually a narcotic. So that's usually narcotic medication. The main standby for arthritis is actually not usually narcotic medicine, it's anti-inflammatory medicines. So the ones that are probably most familiar to you are ones that you probably have in your medicine cabinet. That would be like Advil, Aleve, ibuprofen, Tylenol. These are examples of anti-inflammatory medicines. Or NSAIDs. NSAID stands for non-steroidal anti-inflammatory drugs, is what it stands for. And you'll see these on commercials on television and so forth and so on. But these are usually the mainstay of treatment for arthritis. And they can really give you relief. The issues with this is some people, it can bother their stomach, so you have to take it with food. These medicines, if you're taking them routinely, because remember, these can come as a prescription, you know, prescription that you actually get from your doctor, but these are also available over the counter. And just because they're available over the counter doesn't mean they still can't bother your stomach or have other effects. One of the concerns with anti-inflammatory medicines is that they can affect your liver and kidney. I'm not saying that they will, but they can. So they just have to keep track of them. So if you find that you're taking these routinely, it's important to let your doctor know about it. Let your regular doctor know about it, because they just have to run blood work every once in a while to make sure it's not affecting your liver or kidney. So it's important. So again, even if you're not taking a prescription one, but you find that I take 2 Advil every day, and I've been taking 2 Advil every day for 6 months, well, you should probably let your doctor know about it, because it would fall into this area. Injections. Everybody's probably somewhat familiar with these. These are injections usually for your knee. You know what I mean? Because your knee is pretty accessible. It's very easy to get a needle into your knee. The hip less so. They will do hip injections, but that's usually a real procedure. The knee injection you can usually just get right in the office. You know what I mean? Not a real big deal. Easy for me to say, I'm not getting a needle, right? But they always tell you it's just a little pinch, but I don't think it's that. But anyway, so injections. What are injections? What are we actually giving to you? It's usually a steroid. This is usually injection of a steroid. And so what's a steroid? A steroid is a very strong anti-inflammatory medicine. It's about the strongest anti-inflammatory medicine I can give you, you know, usually in an office. And the benefit of an injection is you're putting it right where the pain is. You know what I mean? So it's going right into your knee joint, for example. That's where the pain is. And these people will get pretty quick relief. A steroid injection will help just about anybody. It doesn't matter how advanced their arthritis is. The difference between one person to another person to another person is how long it lasts. Because if you have pretty mild arthritis, you can get pretty good relief from a steroid injection for a while. You know, usually it'll help you until you do something to hurt your knee again. For people who have really severe arthritis, so sort of like that X-ray going back that I showed you, it might only help for a week or even just a couple days, because it's not magic. You know, that's all that the medicine can do. I had a very nice patient when I first started practice, and she came in and I gave her a steroid shot. I gave it to her knee. She had pretty advanced arthritis, and because the shots had helped her in the past, and that's what she wanted to get. So fine, I gave her that steroid shot, and she came back in a month. And like I said, I was new. I had only been practicing for a couple months, and she said, you know, doctor, that was all fine and thank you, but I think you missed the spot. You know, you missed my knee. And you know, I had only been practicing for a couple months, so I was, you know, but I was fairly confident that I knew where the knee was. And I said, well, you know, how do you mean? And she said, well, because the last time I got that shot 3 years ago, it lasted for for 6 months, and you're shot for a week. And I had to politely tell her the difference is that 3 years ago, her arthritis wasn't nearly as bad as it was now, because she was like that X-ray. She was bone-on-bone arthritis. And, you know, that's an example of, like I said, the history of the arthritis is to get worse as time goes by. And that's an example of it. You know, people who got good relief from a steroid shot years ago, it just may not work real well for them anymore. We'll generally give these shots just about once every 4 months. Because patients will come in and they'll say, that worked really well, I'm ready for my next one, and it was only 2 weeks ago. And you can't do that. Too much steroid is actually bad for bone and cartilage, so you don't want to give too much steroid to a joint. So our rule, it's not a hard, fast rule, but it's usually about every 4 months is the most often we'll give a shot. And that's not a bad rule of thumb, because, you know, honestly, if you need it more than every 4 months, you should probably be doing something else. You know what I mean? This is another type of injection. So we mentioned the steroid shot or the cortisone shot. People are pretty familiar with those. There's another type of shot. They're called viscosupplementation injections. Those are not steroid. I mean, they're completely different. Those are injections of a material called hyaluronic acid. Does anybody know what that is? I have a PhD in biochemistry, so I know what that is. But hyaluronic acid is a component of proteoglycans, which in turn are a component of cartilage. So it's a component of cartilage that you're injecting into the knee joint, but it's not cartilage per se. You know what I mean? It's a component of cartilage, and it can give you some relief. These are usually given as a series of shots. So if you've had them, it's usually a shot a week for like 3 weeks or 4 weeks. That's how these are usually given. The effect of these shots is usually not as immediate as a steroid shot. You know, most people get a cortisone, you know, really in an hour almost, they'll notice the difference. These don't seem to work quite that way. I've had patients where even they had to go through the whole series of shots before they really noticed the difference. So these shots, we'll usually give them as a series, and then usually we'll see the patient back about 4 to 6 weeks later. And usually by that time, you should know if it's really done anything for you. There's been a lot of advertising of these lately. Patients have brought in full-page ads for me that these are new and exciting. And I don't know what they're describing as new, because these have been around for more than a decade. So it's not new. I hate to disappoint patients, because, you know, we're ready to sort of grab onto anything that'll help. But these are not new. They've been around for quite a long time. Some people are doing them ultrasound guided. Like I said, I think I know where the knee is. I really don't need an ultrasound machine to show me that. And I think that's what they're advertising, that it's new and different, but it really isn't. These have been around for a long time. It doesn't mean that it's not a legitimate treatment, but it's not, you know, it's not super new.
It says it's expensive.
Patient have to pay for that?
It's hard to say. I mean, you know, because insurance is always changing. Usually this was something that was covered by insurance, and you have to generally get permission from insurance to give these. And I'll be honest with you, my own ignorance, I apologize. I don't know what patients are getting charged at this point for these injections, because you folks probably know more and more. Insurance is making you pick up more and more costs. So to be honest with you, I don't know if patients are spending anything for these. Back when I was giving them, insurance was covering the whole thing, but you still had to get, you know, permission from insurance to get them. So another non-surgery treatment, especially for knees, would be bracing. So, you know, I think most people get the idea of brace. It's just to give you some extra support around your knee. And these can be soft braces, or they can be pretty complicated braces that even have metal in them and things like that. And some people do get relief from these. My own personal experience, I'm not saying that braces are not a legitimate treatment, but most patients don't like braces. They just don't like wearing them. They find them to be uncomfortable. It's hard to get them to fit right, and so forth and so on. So, I mean, it is a real option, but just practically speaking, a lot of people don't like them. people will tell you it makes them feel old, having to wear a brace. But nonetheless, it would fall into this category. And again, I think you appreciate this is mostly for the knee. It's kind of hard to brace your hip. You know, so this would mostly be treatment for knees. And that's about it. So, you know, there's about 4 or 5 options that we have for treatment of arthritis, you know, that are non-surgery type options. Again, as you think you realize, there's more options for the knee than the hip. You know, the knee is very easy to do injections. The knee is easy to brace and things. It's just not as many options for the hip, but it would be along those same lines, medications, physical therapy, and so forth. So, you know, Mrs. Jones comes back, and again, Mrs. Jones had one of those x-rays, her hip or her knee, so she has a lot of arthritis that we could tell from the x-ray. And, you know, the first time, she hadn't tried anything for it, so she tried a bunch of these things, you know what I mean? Because we don't usually offer surgery as the first option, you know what I mean? Because some people will do these and they get relief, and that's fine. But Mrs. Jones comes back and she said, I've done all these things. You know, I tried the brace, I tried these shots, I tried the anti-inflammatory medicines, this now for 6 months to a year. You know, what do I do? And that's when you start replacement. So when you have that x-ray that shows bad arthritis, you have the story behind it, you've tried a bunch of these things, and it just isn't getting you what you want, well, that's when you start talking about joint replacement. So starting with the knee here. So joint replacement, an option when the pain is severe, it interferes with your daily activities, it interferes with your work. You just can't do the things that you want to do. The goals of the joint replacement, the main goal of joint replacement is pain relief, is to relieve arthritic type pain. That's the main, you know, indication for a joint replacement. I don't mean to sell it short, but it won't make you younger. It won't change your looks, but it will take away joint pain. I mean, that's the main indication for the surgery.
That's why they sell all these
And that has a shaft that goes down into the shaft of the bone. Again, it gets cemented into place to hold it there. And then into that, you put a plastic liner. And that's basically a knee replacement. So there, I told you. I don't want you doing this in your garage or anything like that. But that's, I mean, it's really fairly simple, fairly straightforward. People always ask about your kneecap. This model doesn't have your kneecap. Your kneecap, you know, not the part that you can feel, you know what I mean? If you bend your knee and you feel your kneecap, that's not where the cartilage is. Your cartilage is on the other side. If you could sort of flip your kneecap over, that's where the cartilage is. So what you do is you make a cut across the underside of the kneecap and you replace the underside with a button of this same type of plastic.
How long does that last?
That lasts roughly about 15 years.
Oh, good.
We like to think that the ones we're putting in now will even last longer, and which is important for, you know, our 45-year-old patients and things like that. But that's what a knee replacement is. So the question patients always have, they always say, well, I don't have a kneecap anymore. You do. Because remember, it's half and half. We make that cut across the kneecap. So kneecap, half of it is you, half of it is your bone, and then the other half is that plastic button. And that rides right along the front of the knee joint. So that's what a knee replacement, and it doesn't take 10 hours, or, you know, patients always think that, you know, this is a big, it takes about it's about an hour. It's about an hour, 15 minutes to do that surgery. So it's not a super long surgery.
Is that why you can't kneel?
I'm sorry.
That pin that comes up from the tibia, is that why you can't kneel?
No, some people, the kneeling part, some people just don't find it comfortable. It feels kind of strange. And then the other thing is personal experience. I've seen patients break their kneecap doing that.
Yeah.
And that can ruin your knee replacement. So usually I don't recommend kneeling.
No,
too
I've
much.
told from the beginning, but don't kneel.
So that would be a knee replacement. So again, you have severe arthritis. You've gone through a lot of those options that we spoke about, and you know this would be a knee replacement. And you know, patients will ask about motion and things like that. Most modern knee replacement, you're able to get about 120 to 130 degrees of bend. And the whole purpose of this is to sort of show you the amount of bend that you need for routine activity. So if you can get about 120 to 130 degrees of bend, you can do, you know, most of the things that we would routinely do. Unless you jump hurdles or something like that, you know, but for most of us, for everyday activities, it would allow you to do the things that you want to do. All right, so that's the knee, and you know, what about the hip? So again, same sort of story, you know, has that x-ray that shows bad arthritis. They did these other treatments, they're really not helping. You know, what can you offer for a hip? And again, I think I'll probably use the model. So if my model doesn't fall apart.
Oh boy, I'm not coming to you for it.
Well, whenever I use the computer and I fall around on the computer, I always tell patients I'm a much better surgeon at computers, because they're probably looking at me like, this guy can't even, you know. So model of a hip. Now this model a little different. The clear parts here represent your bone. So I mean, when you're looking at this, you're kind of looking at this. Okay, so this is this whole area of your body. So because when I bring this into the office, patients won't pass out because they think this whole thing is the hip replacement. No. Again, the clear parts, you know, represent your bone. The hip is a ball and socket type of joint. And that's what we're trying to replace. So, you know, on the picture, there's the ball and there's the socket. And again, that's what you're trying to replace. Pretty simple joint. So for the ball part of the joint, what you end up doing is you make a cut across the femur bone up toward the top. That would be this cut. That's the cut that you and you replace it with this metal stem. And that stem goes down into the shaft of the bone. And you can't see it here, but like I said, you're welcome to look at these afterwards. That stem has a roughened surface up here at the top. And usually we'll press fit this. You know what I mean? We don't use glue or any cement. Now, sometimes you have to. If the bone's not real good The quality of it isn't real good. Sometimes you have to cement this into place, but the majority of the hip replacements I do, we press fit them, and then your bone will actually grow into that roughened surface. That's what ultimately holds it in place. And onto that stem, you put a ball. That ball is usually either ceramic or metal. So that would be the ball part of the joint. That's how you replace the ball. And then for the socket, you bring out the bone and cartilage from your socket and your socket. So that's basically a metal hemisphere. Again, I apologize if you were close, you could see on the other side, it has that roughened surface. So again, this is press fit into place and your bone will grow into that rough surface. And then into that, you put a liner. Now the model that I have, we looked around the office, I just couldn't find the other one. This is a ceramic liner. I don't usually use those, me personally. I usually use a plastic liner for anybody who's taking notes. So use a plastic liner. And then that would be the new hip replacement. So again, you know, it sounds really very complicated and so forth, but it's really a fairly straightforward surgery. I mean, this is another surgery that takes about an hour or so to do. It's not a real long
How does that ball stay in there?
It's the tension of your own tissues holds the ball into place. Yes.
I had a little kitten. Her ball sockets were too small for the ball. So they had to make a whole new socket.
This was for
Kitten.
a kitten. Well, I don't want to speak outside of my But these are usually okay. So in other words, you had your knees replaced and you need to get an MRI of your shoulder. You could do that. That'll be fine. So that's not an issue.
Because when I was on jury duty, every time I went through the metal detector.
Oh, yeah.
Oh, yeah.
Oh, yeah.
And I just,
Absolutely. We have an honest face.
Sometimes they don't quite
Several years ago, I broke the pelvic bone. I didn't need an operation. It was just something that I was in hospital for 21 days. But they changed it when they would talk about it. They say something about my hip. And I would keep saying, no, I didn't break my hip. I broke the pelvic bone. Could you point on your chart where the pelvic bone is for me?
Sure. So, this is your femur bone.
Right.
This is your pelvis.
Oh,
That part. And then this is your hip joint.
oh, okay.
But this is your pelvis. Probably where you broke it here. It's quite painful. You usually have to do surgery for it.
Yeah, no, they didn't. I just had to be in the hospital for 21 days. Yeah.
is it true if you cross your legs, you're taking 5 years off the advice of your replacement? You know how people,
I haven't heard that.
Some people only told me that.
No, but I wouldn't walk under any ladders and I would avoid black cats. No, the crossing the legs thing, no. I mean, that won't really wear on your hip. Talking about is what are called hip precautions, where they tell you really shouldn't cross your leg over, things like that. And I mean, those exist. A lot of the therapists and the rehab doctors will talk about that. There's a long list of hip precautions. They sort of make intuitive sense, you know what I mean? They make sense. But again, it was one of these areas of medicine where there was something that sort of made sense, but was it ever proven?
Yeah.
So at the Rothman Institute, they actually did a study of that, and patients did fine. We don't use hip precautions
The only
generally.
thing I can't do
For
is-
regular hip replacement, we don't use hip precautions.
I can't deal. Yeah, it's the only thing I can't
No,
do.
that's it, we were told.
Yeah,
not
you may
to.
find that uncomfortable. Yeah,
Yeah, we
I
were
agree.
always told not.
I tore my meniscus twice. Where is your, I know it's on my knee.
Right, you're
Where on
correct.
your knee is it?
I don't have a good picture to show you of that. The meniscus is not something that you would see on an X-ray. You know what I mean? In other words, the meniscus is not bone, and it's not hard tissue. The meniscus is actually cartilage, so it won't show up on an X-ray. Usually, if you really want to just evaluate the meniscus, you usually have to get an MRI. And it's some of the cartilage that's in the knee joint. You have two of them. You have one along the inside part of your knee, the medial meniscus. You have one along the outside part of your knee, the lateral meniscus.
Mine was in the middle.
It's really what people have a problem with. And they're made of cartilage, and you can tear them. You can get a torn meniscus. Sometimes they'll treat that with arthroscopic surgery. But a lot of times in the context of this talk, especially in older patients, that torn meniscus is associated with a lot of arthritis. And so we usually won't do arthroscopic surgery for that because there's too much arthritis. The real problem in that knee is really arthritis, not the meniscus tear. But that's what the meniscus is. I don't have a good picture to show you or anything like that.
But I mean, it's like, I had it twice. Is it that normal?
You can tear it. Yeah, I mean, you tear it once. You can re-tear it. You can tear it again. So it's not
They
impossible.
gave me a shot.
Usually, for me,
One time they operated, one time they gave me a shot, and the shot was fine.
right, for me, if I have a patient that comes in this tear, but again, remember the group of people that I'm dealing with, I do joint replacements, so most of the patients I see are older, you know what I mean? So they're not sports. You follow what I'm saying. It's not 20-year-olds, it's not teenagers. So most of the patients that I see who come in with a meniscal tear, I'll inject them because usually that'll be enough. That'll get them over the pain that they have from the tear. and they do okay. They don't usually,
It's about 5 years.
yeah, they don't usually necessarily need an operation for that. You know, I'm just going to make sure we went through everything. People asked about the hip replacements. People will ask this. So this, you know, I'm glad we went through the slides because people, what can they do? You know, are there limitations? And some of that we sort of talked about a little bit in terms of the kneeling and so forth. After surgery for a knee, the usual hospital stay could be as short as even a day.
Yeah.
It depends a lot on the patient, you know what I mean? You know, there are other patients like that 91-year-old, I don't think he's going home in a day. And, you know, he may need an extra rehab or something. So he may even go up to the rehab floor, for example. So it's kind of variable. But along those lines, the quick answer to your question, it can be as little. I've had patients go home in as little as a day, and then other patients, you know, it may be a little longer. A lot of that depends on their health.
Where are you located?
Oh, you know, I'm sorry. When I introduced myself, I didn't say that. So I'm with Rothman Institute. I operate mostly out of Nazareth Hospital. So that would be the closest here. And then I operate out of our specialty hospital in Ben Salem. And people always ask where that is, and it's across from the casino.
Yeah.
That's how people know. That's how people find out where that is. It's across from the casino.
Yeah.
But that's where I do most of my surgeries. Every once in a very rare while, I operate down at Jefferson also.
My insurance wasn't accepted at Rothman.
It's a game now.
Diamond jeans. I was very happy with it too. I did all my therapy in jeans, but now they don't do therapy in there.
In there. Mm-hmm.
I was very happy with it.
Very good.
All right. Thank you so much,
All right,
everyone.
Yeah, he didn't have them to take them apart.
Yes, these are my slides. Yeah.
You want to hold it? Because my